and we'll discuss the remaining material for chapter 7 on the bones, the skeleton here and whatnot. Let's get to where we were going. All right, so all right, we talked about interstitial bone growth, how bone grows lengthwise. And that, of course, when we're talking about long bones especially, we have to discuss interstitial growth. And that's the lengthwise growth for bone. And so that involves the epiphyseal growth plates. And we saw how cartilage growth occurred, and then the cartilage tissue would die and degenerate as it became calcified. And then we saw how the bone tissue overtook the old degenerating calcified cartilage matrix and laid bone over that and turned it into new bone tissue. And that's essentially how our long bones get longer, that the epiphyseal plates will basically push the epiphysis, the proximal and distal epiphysis, away from each other, away from the shaft. And that's essentially how your bone grows interstitially. So now we're going to talk about how bone grows appositional. Appositional is like a tree trunk getting thicker and bigger year after year after year. Right? So now we're going to see how that applies to the bone. Okay, so as you know, that your bones from infancy to childhood to adolescence and even into adulthood, they become thicker. So when we're talking about appositional growth, we're going to go and talk about the periosteum and the endosteum. Right, so when we're talking about the actual laying down of new bone tissue, that's going to occur in the periosteum. Remember, our periosteum has two layers. The outer fibrous layer, which is made up of that dense irregular connective tissue, but it's the inner cell layer that is going to have our osteoprogenitor cells, osteoblasts, osteoclasts. So we'll have these cells that are going to basically deposit the bone matrix on the outer surface of the bone itself. Now, while this is occurring simultaneously, the osteoclasts are going to be hard at work in the endosteum there. And so they're going to be busy resorbing that old bone matrix, and its goal is to try to make the medullary cavity bigger and bigger and bigger. So as the bone grows outward and it gets thicker along the circumference there, while on the internal layer and covering there, the lining of the endosteum, the osteoclasts are going to be resorbing bone. So if you look here at these pictures here on the bottom of our screen, you can see here how on the outer layer here, right, the osteocytes, the osteoblasts, osteoprogenitor cells are going to lay down new bone matrix. And so it's going to keep adding it to the periphery. Meanwhile, the osteoclasts are going to be working on the internal lining here along the medullary cavity, and it's just going to be eating away the old bone matrix. So it'll get wider and wider. And so the internal portion of the medullary cavity is going to get bigger and bigger as the outer portion of your compact bone keeps growing outwards. So that's what we're going to see here, right, during appositional growth. So we'll see, all right, that this growth widens and thickens the bone itself, much like a tree. So we've talked about how when bones are growing, right, there's going to be, all right, a certain homeostasis that needs to occur with certain cell activities, cells that are going to be bone building cells and cells that are going to be bone resorbing cells. And then also the same situation is going to be true when we're talking about cartilage, right? We're going to have certain cells that are going to lay down cartilage. Well, when we're talking about achondroplasia, right, this condition you may have seen folks that are achondroplastic dwarfs, and they're usually folks that are short in stature. And it's a genetic trait. And unfortunately, what happens is, all right, when we get that conversion of cartilage tissue into bone, there's a problem with that. And what we'll see is, all right, the chondrocytes themselves in layers 2 and 3, or levels 2 and 3 of the epiphyseal growth plate, are going to fail to actually make more cartilage cells. And then they unfortunately don't undergo fully the hypertrophy that occurs. So they won't get enlarged. And so because of that, we have inadequate endochondral ossification. And we talked about that process of endochondral ossification. And so as a result of that, there's an issue at the growth plate. So as you know, when we're talking about our long bones there, we'll see that these folks don't undergo a complete growing during their childhood. All right, so when they're a child into their teenage years, the limbs will stop growing before they even get to their teenage years. So their long bones will be exceptionally short in comparison to the other bones in their body. So other bones, like for example, you'll see folks, their facial bones, their cranial bones will all develop relatively on par. But the long bones just don't seem to get longer. So they'll have short limbs, but their heads will appear bigger because by comparison, right, to the other bones, right, because they didn't grow and continue to grow, the head will appear to be larger in these folks. They'll have long torsos, but their arms and legs will just happen to be shorter. And again, it's just genetic characteristic in which we get, all right, issues in the growth plate there. So I've talked about all these different types of processes that are going on in bones. Now I want to get into bone remodeling. And bone remodeling occurs throughout your adult life. Now, again, depending on what your body is undergoing will determine how bone remodeling occurs. And I'll explain that to you here in a moment, okay? But understand that when you get to age 25, and for most folks, that's skeletal maturity, most of their long bone growth plates will have closed up and you won't really get any taller, right? That's going to be for interstitial growth. But when bone remodeling, that occurs for a long time. So when we're looking at bone remodeling, we're going to be looking again at what's occurring at the periosteal and the end osteal surfaces of the bone. So the outside covering, and the inner lining there. And so when bone remodeling occurs, we're just going to be replacing bone, all right, that maybe some things have changed. In some areas, in some bones, you'll see this rapid turnover of bone tissue. And in others, you'll see it much slower. So we'll see here in the distal part of the femur, and again, that's going to be, a lot of it has to do with the fact because it's a weight-bearing area, we're going to see a turnover every 4 to 6 months. Same bone though, when we look at the diaphysis of the femur, right, it might not completely be remodeled in the course of a lifetime. Same bone though. So you can see that a lot of stuff is going on and it really depends on what is happening to that bone. All right. So when we talk about bone remodeling, we have to look at the activities of certain cells that are involved. So that's going to be the bone building cells, so the osteoblasts, and then the cells that tear down the bone matrix, and that's the osteoclasts. And it also includes the osteocytes because they play a role in this too, and we're going to talk about this here. So there's two things that are going to influence bone remodeling: hormones and mechanical stress. We're going to start off with the easier of the two, the mechanical stress. So when we're talking about mechanical stress, we're talking about weight-bearing movements, and exercise is, in most cases, going to be some sort of weight-bearing type of movement or activity. And so when our bones are going to be remodeling, we need to have mechanical stress. Ask any person, all right, that has gone and seen their doctor for osteoporosis. And if the doctor is good at what they do, all right, they don't even have to be good at what they do. They should just be doing this anyways. But one of the things that they will tell the patient, besides the possibility of dietary, all right, changes, they will say you need to increase weight-bearing activity. So usually the doctor will say, go for a walk if you can. So here's what's going to happen when we're seeing all right, how the bone tissue, all right, monitors mechanical stress. So the cells that are monitoring the bone matrix all the time, those are the osteocytes. And so they sit in the lacuna there. And so they're monitoring any type of stress or changes in stress on the bone. When that occurs, right, they are going to then signal the osteoblasts to do what they do. And osteoblasts build bone. So they're going to lay down, they're going to synthesize and secrete the osteoid, the organic matrix there. And of course, as you know, when that's like our wet cement, the osteoid gets, all right, secreted, right? And then we're just waiting for calcium and phosphate, for the hydroxyapatite to come on in, all right, those bone salts, those bone crystals, and deposit those crystals along the collagen fibers to harden the bone matrix. And that's what's going to happen. So we'll see an increase in bone mass when we see an increase in weight-bearing activities or exercises. We see a decrease in bone mass, right, when we remove the mechanical stress. So a good way to see that is a bedridden individual, someone that's of older age, that is maybe in a coma, and they're lying in bed most of the time. So a lot of the bones that are used to having stress put on them from body weight, if you're standing, will no longer have that. So you'll see a decrease in bone mass. People that are in a weightless environment, are those astronauts up in space, all right, they need to, they're weightless, so they'll have a significant decrease in bone mass. I shouldn't say a significant, but they'll have a significant decrease in mechanical stress, right, which can trigger decrease in bone mass. That's why they'll have exercise equipment up in space. Literally, they'll have a treadmill there, and they want the astronauts to walk on the treadmill. Well, at first, it's kind of hard to do that because you can just float right off the treadmill. But they have these huge rubber bands that will go over your shoulders and literally strap you down onto this treadmill and push you against the treadmill so you can walk. And it creates that weight-bearing stress there. So it helps decrease your bone loss. All right, so the other influencer of bone remodeling are going to be hormones. So there's a whole list here. The good news is you're going to see a lot of these hormones in chapter 17 when you study the endocrine system in 211. But we're going to kind of give you a little bit of a brief introduction here. So what's a hormone? Hormone is a chemical, a bunch of molecules that get released into the blood and will travel to what we call target cells. And it will stimulate those target cells to do something, either to make something, to release something, whatever. Okay? So cells will produce these hormones. The hormones will go into the blood, act as a chemical messenger, travel throughout the body, and then it'll affect certain tissues and cells. And how it does it is it binds on to a special receptor that are on these target cells, and then it'll cause that cell to undergo a series of changes. Now, the nice thing is you'll talk more about that in detail in chapter 17. But for right now, basically, these hormones, these chemicals are going to cause these target cells to do something, either to make a hormone of itself, on its own, and secrete that to do something else. In this case, since we're talking about bones, we're going to see how these hormones are going to affect the rates of chondrocytes, right? That's the cell that monitors the cartilage matrix and helps to create cartilage matrix, osteoblasts, and osteoclasts. And so depending on what hormones are being released are going to determine what those cells do and how that affects the bone integrity in the matrix there. So the first one, real easy, growth hormone, also known as somatotropin. It is made in the anterior pituitary gland. This is something that you should definitely know. And when it's triggered to be released, it releases growth hormone into the blood. Growth hormone will travel to the liver, and it will stimulate, all right, the liver to make another hormone, all right, also known as somatostatin, but we call it IGF, or insulin-like growth factor. And so now both insulin-like growth factor and growth hormone are going to affect the epiphyseal plate in our bones. And it'll stimulate, all right, the growth of cartilage. Because once you stimulate the growth of cartilage, the rest, it's like a cascade. The rest will fall into place. Once we increase our cartilage cells and they start to enlarge, the rest will occur. Those cells are going to eventually calcify and then they'll die. And then our bone tissue will replace that degenerated calcified cartilage matrix there. So both of these hormones are going to stimulate the growth of cartilage at the epiphyseal plate. So that helps you to grow, get taller. Thyroid hormone. A lot of us think of the thyroid hormone as a hormone that is going to regulate the metabolism. And it's true. Thyroid hormone plays a huge role in what we call the basal metabolic rate. Okay, that's just the basic functions. Like when you're sleeping at night and you go to sleep and lying down in bed, your body is still having jobs to do. It still has to make certain hormones. It still has to repair tissues. All right, thyroid hormones help a lot with that. It helps these cells, all right, that need to go about their business, all right, and that basic business, we call that the basic metabolic rate. Well, in this case, thyroid hormone, which is obviously made by the thyroid gland, is going to affect the basal metabolic rate of bone cells. And so it'll help, right, with the normal activity of these bone cells at our growth plates. So if you have a decrease in thyroid hormone, then that could potentially decrease the how much you can grow. I'm not going to say it stunts your growth, okay, but you might not reach your full potential of being 6'2" and you're only like 6 foot. All right, so thyroid hormone is important, and so that's why it should always be well maintained. All right, sex hormones, obviously. All right, some of you might be too old to remember this, right? Because puberty may have been a long time ago, but estrogen and testosterone, okay, once the onset of puberty occurs, this is when a lot of these quote unquote growth spurts occur. And it's because we're going to see not only an increased rate of the cartilage growth at the epiphyseal plate, we're also going to see, all right, the ossification process at the epiphyseal plate also increase. Okay, so it's going to happen quickly. So hence, you get these growth spurts. Right? Well, you'll see, hey, you know, just a couple of months ago, you know, my son was 3 inches shorter than what he is now. And so that testosterone is pushing those cell tissues, okay, the chondrocytes there, and also the osteoblasts and the osteoprogenitor cells to really turn over that cartilage tissue into bone. Okay, so we're going to see this occur, all right, I won't say tenfold, but significantly more during puberty. Glucocorticoids, they're a fun group of hormones to deal with. Now, these are steroid hormones, okay? And again, you'll talk more about those in chapter 17, the classification of hormones. But steroid hormones, usually the precursor, a big ingredient of steroid hormones is cholesterol. All right, and this class or group of hormones comes from your adrenal glands, okay? Specifically the adrenal cortex, which is the outer layer of your adrenal gland. So what will happen is, okay, when your blood sugar levels, right, are really low, glucocorticoids will be secreted. And so what they'll do is they help to increase your blood sugar levels. But one of the problems that we'll see is also if large amount of glucocorticoids are being released, it can facilitate an increase in bone loss. And so we see this quite a bit in much older individuals, and especially in individuals that take these glucocorticoids chronically all the time. Kids with asthma, perfect example. All right, they'll take these steroid hormones and or this medication, and if they're taking it daily, all the time, right, depending on the amount that is being given to them, this can significantly cause, all right, some impairments at the epiphyseal plate there when we're dealing with cartilage creation. All right, so it's always cautioned, all right, especially in kids that are asthmatic, that they try to give them different types. Glucocorticoids are depending on how bad the symptoms are. there really shouldn't be the first medication that should be prescribed to these children. Okay, there's several other classifications. Okay, this is one of those things. I mean, they're highly effective, but again, it's one of those things where you have to decide, well, are the side effects or the adverse effects worth, the actual condition to what you're treating? So again, it's always one of those things you have to weigh in the consideration and see, it's a cost benefit analysis there. Okay, so here's another one, serotonin. Okay, now we'll talk a little bit more about the function, not specifically of serotonin, but of what neurotransmitters are. But neurotransmitters are chemicals that are released between a neuron and another neuron, or a neuron and an end organ, which can be a gland or a muscle. Okay, so it's a chemical means of communicating from one cell to another, right? But also it plays a role in hormones here. So in certain situations, we found out that our bones will have these serotonin receptors. So it's nice, all right, when everything's normal. Okay, so when bone remodeling occurs and everything's fine and your serotonin levels are great, everything's good. But now what happens if you've got a young person, and say, for example, you notice that your 14-year-old child is somewhat depressed because of everything that's going on with COVID, and this whole pandemic has really gotten them stressed out. So you go and take them to the doctor, and the doctor's like, well, you know what? They seem depressed. I'm going to write them a script for Zoloft, okay, which is an SSRI, selective serotonin reuptake inhibitor, certain classification of drug. So they give this prescription to the kid, and now this child has tons of serotonin floating around, lots and lots and lots. Problem is, okay, if the levels get to be too high, these osteoprogenitor cells cannot become the cells that build bone. So now, all right, we aren't able to get bone tissue being made like we used to. And so overall, long term, this could lead to low bone density disorders like osteopenia. Okay, osteoporosis is pretty significant, but osteopenia is the big one here. And all because, unfortunately, this pandemic occurred and this child had a really tough time dealing with it. And so they became depressed, and then their doctor was just trying to help them out. And they prescribed them an antidepressant, and that antidepressant increased the serotonin levels so much so that it has slowed this person's growth down. So again, you just have to be careful with that. Okay, so those are some of the hormones that play a large role, okay, and affect our bone remodeling, which brings us to our next concept in talking about an important ingredient in our bone, which is calcium. So we have to regulate, and calcium is not the only thing, but we have to regulate the levels of certain molecules, substances within our blood. So we're going to talk about how we regulate blood calcium levels. And calcium plays a large role. We're about to get into, in chapters 10 and 12, right, some of the significant roles of calcium. We're going to learn about how it plays a role in muscle contraction. We're also going to see how it plays a vital role in the release of neurotransmitters in our neurons through the process of exocytosis. Right, and then we'll also see, when you're in 211, right, when you're learning about the heart and the different types of cells within cardiac tissue, we're going to learn about these awesome pacemaker cells and how they stimulate the heart and how calcium affects these pacemaker cells. And then without calcium, we wouldn't even be able to clot blood, or we wouldn't have effective blood clotting. And so you can see that calcium is very, very important. So after we go over chapters 10 and 12, I think you'll have a new appreciation for calcium. So that's why we really have to monitor and make sure we regulate the proper levels of calcium in our blood. If you have high blood calcium, then you are known as someone that is hypercalcemic. calcemic. If you have low blood calcium, then you are hypocalcemic. So we have two hormones that are going to help regulate that blood calcium level. We have calcitriol and parathyroid hormone. The first one there, calcitriol, should look somewhat familiar to you. Calcitriol is vitamin D. All right, so we talked about how vitamin D is made, right? Well, basic vitamin D. Now you can get vitamin D from other sources, right? Dairy companies love to advertise that their milk is rich in vitamin D, right? And so there are certain foods that are rich in vitamin D. But I like to get my vitamin D the old-fashioned way. I like to get it from the sun. And my keratinocytes like to be able to help out with that. So when you step out into the sun and the ultraviolet radiation strikes your keratinocytes, you start to produce cholecalciferol. All right, so cholecalciferol is going to be released into your blood, and it's going to circulate throughout your body. All right, and it's going to travel to the liver. And in the liver, it comes across some of the many liver enzymes that live there, and they convert, all right, that cholecalciferol into calcidiol, which is good, but it's not great yet. So what will happen is calcidiol circulates throughout your bloodstream, and then it finds its way into the kidneys. And the kidneys have some enzymes there that go to work on the calcidiol and convert it into calcitriol. That is our active form of vitamin D. And what does it do? It is going to increase the absorption of calcium from your small intestines. Awesome. We don't want to lose any calcium because we're in this situation, we have low blood calcium levels. So we're hypocalcemic. So that calcitriol starts to absorb calcium from the small intestine and into the blood. So our blood calcium levels increase. Well, parathyroid hormone, PTH, is going to help also to increase the rate of conversion of calcidiol in the kidneys into calcitriol. So PTH helps to increase that. All right, cool. I like parathyroid hormone. It teams up with calcitriol to increase my blood calcium levels. So here you can see this awesome picture here. Okay, you have an either or situation. The sun can help you make, all right, vitamin D, or milk can help you get that vitamin D. Point being is once it's into your body and it starts to circulate through your blood, it's got to go to the liver first. It gets converted into calcidiol. Awesome, but we're not there yet. Then it travels to the kidneys. Then it gets converted into calcitriol. Perfect. Now we've got, all right, our hormone that is going to increase the amount of calcium that is absorbed from your small intestine. So meanwhile, you've got calcitriol doing that in the small intestine. Your parathyroid hormone is going to be released by your parathyroid glands, and they're located on the backside of your thyroid gland. And so when they detect that there are low blood calcium levels, when you're hypocalcemic, right, parathyroid hormone gets produced and released into your bloodstream. So we already talked about how it affects the kidneys and the conversion of calcitriol. So what does PTH now do, and what does calcitriol do on some of the major organs? Well, look at the organs listed below: bone, kidneys, small intestine. So we talked about, all right, the small intestine in respects to calcitriol, okay, because only calcitriol is going to increase the absorption of calcium from the small intestine. Parathyroid hormone does not have anything to do with that. It's a great test question, so don't be confused. Parathyroid hormone has nothing to do with the small intestine. Calcitriol is the only hormone out of these two that affects the small intestine. They both will affect bone in the kidneys. So in the bone, they work together. That's what this means, act synergistically. So each of them helps to boost up the overall outcome. So they increase the release of calcium from the bone. Well, how do we do that? Well, we got to go and recruit the only cell that can break down bone matrix, and that's what we do. All right, so PTH and calcitriol both will increase osteoclast activity in the bone to help destroy the osteoid and release calcium and phosphate. And so that will help to bump up calcium and phosphate levels in your blood. Now, the kidneys, okay? While this is going on in the bone, all right, the kidneys now are affected by parathyroid hormone and our calcitriol to get rid of less calcium. So it's going to decrease excretion of calcium. At the same time, it's going to increase calcium reabsorption. So basically what I'm saying is your kidneys are going to make sure that there's no calcium or very little calcium in your pee, in your urine, right? They'll increase both the resorption of calcium and phosphate. So that's all. I mean, all that is going to help to boost your blood calcium levels. And that's what this picture here is showing you. Right? It is showing you how parathyroid hormone and calcitriol are going to help increase your blood calcium levels, because that's usually what's going to happen. Your blood calcium levels dip down, right? And then you have the receptors there in your body, which are going to monitor those low blood calcium levels, and it's going to stimulate the release of these hormones and the secretion and synthesis of these hormones, so we can get the organs involved, your bone, your kidneys, and your small intestine, to help to increase your blood calcium levels back to that normal range, that homeostasis range there, or homeostatic range. Which brings me to rickets. All right, now last class, I think, or the first class that I was talking about the bones, so that might have been 2 classes ago, I was mentioning how it's very important that your bones have the appropriate ratio of organic to inorganic matrix. Okay, so rickets is a result, all right, when that ratio is out of whack. And what happens is, right, you have a vitamin D deficiency. And we already know what vitamin D does. That helps to increase blood calcium levels. So therefore, if you're low in vitamin D, then most likely you're not going to have a lot of calcium available. So you're going to be calcium deficient. And when you're calcium deficient, all right, that calcification process, what is that? That's the hardening of the osteoid. So we'll see that the osteoid doesn't get hard and rigid like it should. So it's kind of, I don't want to say rubbery, where, you know, I don't want you to think your bones are rubbery, but they're soft. And so areas where you're going to see weight bearing, you're going to see some deformities. So in the lower extremities, you'll see in folks having a bow-legged appearance there. All right, their knees will kind of bow outward like they've ridden a horse. Okay, so you'll see some just bone growth deformities. Also, we'll have decreased blood calcium levels. And we talked about all the, not all of the functions, but the important functions of calcium in our body. And we talked about how calcium is involved in muscle contraction, and it's involved in nerve tissue function. So what will happen is you'll have these cramps and these twitches, this muscle tetany that will occur, and that's due to low blood calcium. So you really shouldn't see that here in the United States. Really what you'll see it is in third world countries or developing nations, right? But if you do see it here in the United States, most likely it's one of 2 things: malnutrition, or this person just does not get outside and they're not getting enough vitamin D synthesized in their skin. And you're seeing that actually in more people, especially in city areas, because just more kids don't go outside like they used to. They'll sit inside and watch TV or play video games. I mean, and so unfortunately, we're seeing, you know, rickets. It's not an epidemic or anything like that, but we're seeing it more than we should. All right, this leads me into calcitonin. Calcitonin, all right, we talked about what happens when blood calcium levels are low, when you are hypoglycemic. Now, let's talk about when blood calcium levels are high, when you're hypercalcemic. So we have another hormone that is just perfect for this, okay, and that's calcitonin. All right, so where does it come from? It comes from the thyroid gland. And so when our blood calcium levels are too high, like we'll see that when you're working out, exercising, for example, All right, so calcitonin gets released and it inhibits osteoclasts. So now they can't break bone down. So they can't release calcium into the blood. Okay, so what we'll see now, not only have we inhibited the osteoclasts, we are going to tell the kidneys, hey, guess what? Our blood levels are high of calcium. Can we get rid of some? No problem. The kidneys are going to increase calcium in your urine. So now, instead of having very little to no calcium in the urine, as we saw with PTH, okay, and calcitriol, now we're going to see high amounts of calcium in the urine because we're trying to get it out of the blood, filter it out of the blood so we can drop it down to normal levels here. All right, we're almost done with this chapter. So there's two more things I'd like to talk about. And I told you that we were going to see this when we get to the ends of these chapters, the effects of aging on whatever topic or chapter that we're talking about. And so I can't talk about bones and not talk about fractures. So we're going to talk about that here in a moment. All right, so two ways that aging is going to affect bones. One is going to be through the tensile strength of bone. Tensile strength is how much a bone can like twist or bend before it actually snaps, right? So what we'll see is, remember what I said, in the aging effects, everything slows down. Cells make less of what they normally make, okay? So we're going to see that the osteoblasts are no different, and they're going to decrease the amount of protein synthesis, all right? And if that's the case, that means you're going to have less collagen in your osteoid. That's a problem because we have now significantly reduced the organic part of our equation. Remember, we want to have a certain amount of organic material and inorganic material in healthy, strong bone. Well, now we've significantly reduced, all right, the amount of organic material, and we've left the inorganic material relatively unchanged. So as a result, all right, in comparison, all right, the relative amount of inorganic material increases because we've significantly reduced our organic. And so what happens to the bone? It becomes more brittle and easier to break. All right. Also, when we're talking about aging effects on bone, we'll have less calcium and phosphate and other minerals that we need for proper bones. So when that happens, right now our bone matrix has become less, so it's thinner and now weaker. And again, it could potentially become more prone to breaking. So when we see this thinner bone or this weaker bone, right, we have a term called osteopenia. And let's talk about osteopenia. Right, we'll start to see this in the third and fourth decades of life. And this will occur in pretty much everybody the older we get. Now, of course, it varies from individual to individual because of genetics and activity and whatnot, right? But what we'll see in people with osteopenia is the osteoblasts, right, they start to slow down. Whereas the osteoclasts are just chugging along like everything's fine. Boom, boom, boom. Life is good. So osteoblast activity is decreased and osteoclast activity just keeps going. And so what we'll see is, again, now we'll see that there's a skew, all right? We've lost that normal balance between those two cell lines. And so that's going to affect our bone matrix. So we'll see this, all right, quite a bit in the vertebra. I see it all the time in the spine. I look at x-rays and MRIs, easier to see in x-rays all the time. And I can tell if somebody has osteopenia just by looking at the picture. Or osteoporosis, to be honest with you. All right, so we see quite a bit of it in the vertebrae there, the spine, your jaw bones, and then the epiphysis, all right, especially because that bears a lot of the weight there. And unfortunately, ladies, this happens more often to you than it does to us men. And that's just, I hate to say it, that's just how it is. So we have osteoporosis. Now, this is the one that gets a lot of attention. And this is when we've reduced the bone mass so much, now we're really starting to compromise the functioning of the bone, especially when it comes to support and protection, all right? But we also have diminished its ability to act as a storage site. So a lot of things occur. So again, Osteoporosis is going to be seen in the older population, but much more in women than it is with men. And so when we talk about the effects of aging, all right, we're going to see decreased vitamin D for a number of reasons. Obviously, most of our hormones are going to start to taper off after our third and fourth decade there. So we're going to see a significant drop off in growth hormone and the sex hormones, estrogen and testosterone. So all of that is going to help to reduce that bone mass that you're used to seeing. And we already talked about the role that those hormones play in helping to build bone and help with remodeling of bone. Now we've just taken a bunch of key players out of that proper bone remodeling. So we're going to have issues. So a little bit more of specifics here of osteoporosis, right, is going to be one, we're going to see it in older population, especially in that older population that are female, because once menopause occurs, you're going to get a significant decrease in estrogen and progesterone. So that will play a role. Smokers, we see osteoporosis way more. If you're of Caucasian descent, if it runs in your family, and if you just sit around and don't do much, this is all a risk. And so there's always that possibility, especially in the older population, of a fracture. And I've seen so many hip fractures from osteoporosis. And also you'll see compression fractures all the time in the spine. But we'll see, all right, fracture in areas where there's a high amount of weight bearing and a lot of movement there. So the best way to really deal with this problem is to make sure that it never becomes a problem. So early on in your younger years, make sure that you're getting as much activity as possible, because then your body kind of builds on that and stores it up. So diet and physical activity are the best ways to prevent this from happening, okay? But in certain situations, all right, eventually, you can't run away from genetics. So medical treatments, interventions, pharmacology, certain drugs can help with that. And again, what we try to do is just try to slow that loss of bone tissue. All right, let's talk about fractures. Remember, this is the last part here, just talking about fractures and how they repair themselves. All right, what is a fracture? It's a broken bone. And there's different types: stress, pathologic, simple, and compound. Stress, right, is usually on repetitive, increased physical activity. See a lot in runners, older runners that get in many miles a week. They'll complain of foot pain. Take a picture of the foot and you'll see it right there as clear as day. And in some cases, you'll see a break right in the bones there of the feet. Pathological fracture, this is when you have some sort of disease process going on. Okay, it can be, for example, a bone cancer, osteosarcoma. All right, osteoporosis can cause a pathological fracture. So the bone is becoming weakened, and then you fall on it weird, or you take a weird turn and it snaps. Simple and compound fractures. A simple fracture is a broken bone that's not penetrating the skin. A compound fracture is a broken bone in which one or both pieces of the bone have fractured or pushed through the skin. All right, so this figure 7.16 is showing you all the different types of fractures there. If you want to take a closer look, be my guest. All right, it's always interesting to see. But I want to talk about the last part here of chapter 7, and that is bone fracture and repair. All right, so what goes up must come down. If a bone gets fractured, it's got to heal. Okay, so a simple fracture takes 2 to 3 months. Compound, depending on how bad, will take much longer. And in some cases, require surgical intervention where you might need rods or pins or screws or whatnot. So here are the 4 steps of a fracture. First, you have to break the bone. As we know, when a bone is broken, right, bones are highly vascularized. So bones, okay, when they break, you are going to damage blood vessels. And that's what happens here. So we broke our bone, blood vessels got torn, and so they bleed. And so blood will fill that area there. And so we get what's called a hematoma, right? A blood tumor. So it's filled in all that area in which there was a fracture, which is good because you want a hematoma there, because what's going to happen now is we're going to start to repair that area. So in step 2, we get the formation of our soft callus, or what we call the fibrocartilaginous callus. I like to say soft because it's much easier to say. All right. So our soft callus occurs because in our blood, all right, we have fibroblasts that rush in. What do fibroblasts do? They make collagen. Chondroblasts will infiltrate that area, and they'll start laying down that dense connective tissue of the cartilage matrix there. So they're producing that dense, regular connective tissue, very strong. And so a mixture of all of this produces our soft callus, also known as, all right, our fibrocartilaginous callus. All right, so if you starting off with our hematoma, that creates what we call our procallus. That's like our scab. Right, and now we're going to start with our soft callus, which is going to be much stronger than just clotted blood. Right now, we're throwing some dense, regular connective tissue in there, and our fibroblasts. So that's what we're seeing here in our second picture. Okay, so here you can see now our blood callus, right, that procallus is it's gone away, and we've replaced it with, all right, collagen and tons of cartilage matrix here. So that's our soft callus. Right, so that's in step 2. Step 3, we're now going to convert our soft callus to our hard bony callus. So the osteoblasts that are near that area, okay, start to infiltrate and replace that soft callus with our bony callus. And so because now we're converting it from cartilage tissue into actual bone tissue. And so this goes on for weeks. And so now we can see we've created this early form of bone, right? It's that lamellar bone, that primary bone, which is kind of like loosely organized. It's not going to be as strong, but it's still going to be pretty strong. It's going to be enough to get the job done. All right, but that's that primary bone. It's not our finished product yet. But now, all right, we've got some bone tissue in here. So what do we have to do? Now we just have to remodel that site over. And so that's what we do in step 4. We're just going to remodel over, all right, that hard bony callus there. And then that's when we bring in that beautiful lamellar bone. And so I misspoke earlier. I called it lamellar bone. Woven bone is the primary bone. Then we're going to replace it with lamellar bone. That secondary bone. And so that comes in, and we just start to remodel the inside of our bone and try to get it back to its original appearance here. And that's what we're seeing here. You can see in step 3, we still, in the medullary cavity here, we still have some of that trabecular bone there. But here in step 4, we got rid of all that. We've laid down some really nice, hard, compact bone here at the fracture site. And you will still have a little bit of a thickening there, but over time, then eventually we'll get down to the point where you almost don't even notice it. But we've reestablished the continuity of the medullary cavity, and we have our nice compact bone with our soft trabecular bone, or our spongy bone on the inside. And that, my friends, is how you remodel fractured bone. All right, so that is it for chapter 7. That's a long chapter. I'm going to just kind of segue right into chapter 9 here. Come on. All right, let's move on right into chapter 9 and talk about articulations. I mean, this is the perfect chapter to move into after talking about bones. Now you've heard me mention articulations all the time, not all the time, but frequently. And so I figured perfect chapter to talk about it now. So articulations are joints. What is a joint? It's a place, right, in which 2 or more bones or bones and cartilage or bones and teeth are joined together. Right? So normally, most of the time, we're going to be talking about bones. So it's where these 2 bones come together, connect to one another, all right? And we'll see movement here. And so when we talk about our joints, of course, being anatomists, we want to classify everything. So when we classify our joints, we classify them on two things: structure and function. Well, that's code for we classify joints by anatomy and physiology. Structure and form is anatomy, function is physiology. So that's what we're going to do. We're going to classify these joints by how they structurally are, what they look like, okay? And then we're also going to classify them by what they do or how they move and things like that. So structural classes, there's three: fibrous joint, a cartilaginous joint, and a synovial joint. Fibrous joint are going to be when the bones are joined together by dense connective tissue. Cartilaginous joint is when bones are joined together by cartilage. And then finally, the synovial joint are going to be when the bones are joined together, right? Not just by ligaments, but also by a capsule. And in that capsule, we have a joint space there, and we filled that joint space with fluid. So synovial joints are fluid-filled joints. Okay, so we have our fibrous, cartilaginous, and synovial. So those are our three structural classes. We also have three functional classes: synarthroses, ampharthroses, and diarthroses. Synarthroses are immobile joints. And so they can either be fibrous or cartilaginous, which means they can either be joined by dense connective tissue or the bones are joined by cartilage. Ampharthroses are going to have some mobility to them. And again, they can be fibrous or cartilaginous. And then finally, the diarthroses, those are the freely mobile joints. Okay, these have the most motion. And so all the synovial joints fit into this category. Okay, so all those joints that have fluid in them, that have a capsule that surround the bones that are articulating with one another, right? Those are diarthroses. So an important characteristic when we're talking about joints is joints are where bones meet each other or contact one another, but they're also going to be a place where movement is supposed to occur or can occur. Right, so when we're talking about movement, right, and we're dealing with a joint, we call it the range of motion. How much movement occurs at a joint? Is it a lot? Is it a little? Is it none? So when we're talking about ranges of motion, right, our motion ranges can go from no movement whatsoever to a heck of a lot of movement there. Right, so basically when we look at the anatomy or the structure of a joint, that's what's going to determine how much mobility it has. And as a result, it'll also determine how much stability a joint has. Two things when we're talking about joints, two concepts that you need to know. One is range of motion, which is the mobility, how mobile a joint is, but also how stable is it? Okay, is it prone to dislocation? All right, so the interesting thing between mobility and stability is that we have an inverse relationship. All right, an inverse relationship is that if you increase one, you decrease the other. So we saw that in chapter 2 when we were talking about hydrogen ion concentration in a solution, or protons, when we were talking about acidity and alkalinity. All right, acids and bases, remember pH scale? And remember how if a solution has a high concentration of hydrogen ions, it'll have a low pH value. So you increase one, you decrease the other. So that's what we're going to see here. Right, joints that have a lot of stability will have very little motion or mobility. And joints that have a lot of mobility will have decreased stability. So the more mobile, basically you can say the more mobile a joint is, the less stable it becomes. Oops. So that's what this picture is kind of showing us here. You've got this person climbing this rock face here, and you can see on this little arrow figure here, All right, we go up here to the sutures. We've seen suture joints before when we were studying the skull. And you noticed, right, there's not a lot of motion and movement in between suture joints. So they're relatively immobile, but they're very stable. It's very hard to dislocate. I have not met a person that has dislocated their frontal bone on their parietal bones. I've never met anybody. And then if we go down here to the bottom of our picture, you'll see the shoulder joint here, the glenohumeral joint. That joint is very mobile. You can make arm circles. You can do all sorts of stuff with your upper extremity. So it's very mobile, but it's easily dislocated. Okay, you're more apt to dislocate your glenohumeral joint than you are your suture joint there, your coronal suture. So keep that relationship in mind. You increase one, you have to decrease the other, and vice versa. So let's roll through a couple of these joints. Let's start off with the fibrous joints. Okay, so we're going to start to talk about, all right, joints, bones that are connected to one another by dense regular connective tissue. And just to kind of give you a clue about dense regular connective tissue, that's tendons and ligaments, stuff that's that strong, are going to be holding these bones together. So you should know this, these joints do not have a cavity. So they're either not going to move at all, or they're going to be slightly mobile. So there's three types: gomphoses, sutures, which we've seen already, and syndesmoses, which we're going to talk about here. You've already seen a syndesmosis joint when we were talking about the forearm. We're going to revisit that here in a moment. All right, so our gomphoses, one of my favorite, it's a peg in the socket, your tooth. Okay, how your tooth sit in your mandible and maxilla is a gomphoses. And these teeth are, let me zoom in here, they are held into place, right, by what we call periodontal membranes, these tiny little ligaments that attach from the bone of either the maxilla or the mandible, and they hold the tooth in place. So that is a membrane, okay, it's not cartilage, so therefore it falls into a fibrous joint. And so they function as a synarthroses. Okay, like I said, very little movement, if any. Technically, they shouldn't move. But for those people that have braces, obviously they do move. Okay, so that's a gomphoses. Sutures are the second type of fibrous joint. Okay, and those joints, right, are going to be held together, okay, by that dense connective tissue there. And you'll see with those suture joints too, it's really cool, all right, how the two joints lock in with one another, because they have these irregular edges there that kind of like a zipper helps to hold it in place. All right, so again, we're dealing with a synarthroses. Now, for the most part, okay, when you're younger, right, these joints will not have fused, but as you become older, they fuse and ossify, and therefore they're not really a joint any longer. So in the younger days, all right, when you're a kid, even teenagers, right, you'll still have these joints present, but eventually they'll ossify over and they'll completely fuse, and you won't have any motion and movement there. All right, the syndesmoses, this is our last fibrous joint. We saw this when we were talking about the upper extremity there in the forearm, of how the radius and the ulna, how the radius will pivot over on top of the ulna during supination and pronation. So in between, all right, these bones, you'll have an interosseous membrane, and that's a dense connective tissue that helps to keep both of those bones that are parallel to one another at a fixed distance from each other, so they're not bumping into each other. It's wonderful. All right, now in this case, this joint acts as an ampharthroses. So that means there'll be a little bit of motion and movement in there at that joint, which makes sense, okay, because of what goes on between these two bones here. But their basic premise, all right, for this joint is to provide that pivot point. So the radius can pivot over the ulna when you're going from supination into pronation. So that's our syndesmoses. All right, going on into our second type is the cartilaginous joints. These are going to be the joints in which the bones are going to be connected by cartilage. And since we're talking about the skeleton, we're only going to be dealing with hyaline cartilage and fibrocartilage. Again, there is no joint cavity in this type of joints. All right, so these type of joints will either have no movement or just a little bit. And there's two types, synchondroses and symphyses. Okay, you've seen both of these. Okay, the synchondroses are going to be in our epiphyseal growth plate. That's where hyaline cartilage is going to be located in between the epiphysis and the diaphysis. That's actually considered a joint. Okay, but it should not be movable. All right, so that's a synarthroses. Now, we didn't talk about this really in too much detail, but there's actually considered to be a joint between your rib and the costal cartilage. We call those costochondral joints, and they are joined by that cartilage there that is going to eventually articulate to the sternum. So it's not really a lot of motion that occurs at that area there, but it's important that we have the ribs articulating with the cartilage, because when you're undergoing breathing, you'll get into more detail about that. It allows motion and movement of the ribs as you inhale and exhale. And then our other type of joint is the symphyses. And we've seen this because we just got done with the axial skeleton. And we're going to get into more in detail in the appendicular skeleton. But with the symphyses, we're going to be talking about fibrocartilage. And we know its role there is to act as a shock absorber and resist compression. And so we see this in the intervertebral discs in your spine and in the pubic symphysis between the two os coxa there of your hip. All right, so these joints, we will have a little bit of movement here. Okay, hence that's why when you're bending and twisting and turning in your spine, right, some of that mobility comes from the intervertebral disc joint there. So those are the symphyses. So I should bring this up because we were talking about the costochondral joints. I should definitely talk about costochondritis. And basically, costochondritis is going to be an inflammation of the costochondral joints, right, that in some situations, depending on where the pain is occurring, a lot of times people will think, especially if it's on the left side, they'll think that they're having a heart attack because it's going to be right over those rib cartilage right here. You can see, since we're on the anatomical left, if any of these areas here get inflamed, it'll be on that left side. People freak out and they'll think that they're having, a heart attack. Right? But usually what will happen in most cases, people have no idea what caused it. And a lot of times, more so, it will be from trauma, okay? But also there's a possibility that there can be infection. One of the best way to treat this type of scenario is to give that person anti-inflammatory drugs. Now, does it really matter if they're non-steroidal and steroidal? It depends on the history and the health history of the patient. All right. I mean, if you really want to knock this thing out hardcore, you throw them some steroidal anti-inflammatories, give them some glucocorticoids, boom, you'll knock it out. Okay. But depending on their history, non-steroidal anti-inflammatory drugs are fine, or NSAIDs are good to go. All right, let's talk about our last class of functional joints, and that's the synovial joints. Okay, these guys, not the synovial joint, functional, structural. Synovial joints are going to be a joint that has a fluid-filled joint cavity. So all synovial joints fall under the classification when we're dealing with function. They fall under diarthrosis. All synovial joints. So that means all synovial joints that are diarthritic are going to have the following features. We're going to have a joint capsule. Okay, so therefore that joint capsule surrounds a cavity. In that cavity, we're going to have fluid. Right? Also in that cavity, we're going to have articular cartilage. Remember, that's that hyaline cartilage that we talked about that lines the end of bones and helps to reduce friction and acts as a shock absorber and it protects the ends of the bones. And then we'll also have ligaments, nerves, and blood vessels. We're going to talk about all these. Okay, so here's a nice picture of our synovial joint. So you can see you have two bones that are articulating with one another. At the ends of these bones, we have our nice, beautiful articular cartilage. And then we'll have, all right, this space here. And in that space, we're going to have fluid. And so you can see where this purple is, all right, that is the synovial membrane. We'll talk about what that does in a moment. And then outside of that, all right, we have this thicker layer of tissue, and that's going to help to make up the joint capsule. And then you'll notice over here on this part of our picture, right, part of what we're seeing on this joint capsule is going to be a ligament. And so we're going to hit all that important stuff. I'll go back and forth and show you. All right, so let's start by talking about the joint capsule or the articular capsule. Double layered joint capsule. How nice is that? It seems like a lot of things pertaining to bone happen to be double layered. Periosteum, right? For example, right? Perichondrium. So our outer layer is going to be fibrous. All right, we've seen this before. Makes sense. Have the outer layer be fibrous because that's going to help strengthen the joint, prevent it from being yanked apart, or having one bone slide ridiculously, excessively compared to the other. All right, and then on the inside, in our inner layer, that's the synovial membrane. That's going to be made up of a loose connective tissue, areolar connective tissue. Right, and it's going to make the synovial fluid. Interesting fact is that the synovial membrane is going to be on the inside of the joint capsule, but it will not cover the articular cartilage. So anywhere where there is no articular cartilage, you will see the synovial membrane there. You don't want it covering the articular cartilage because every time you move, you destroy, because the two bones would squeeze together, they'd pinch the synovial membrane and damage it. So you just don't even put the synovial membrane on top of the articular cartilage. All right, speaking of the articular cartilage, we've seen this before. Articular cartilage is hyaline cartilage. It's going to be on the bone surface because it helps to protect the bone. It helps to decrease friction, and it helps to act as a shock absorber. Interesting fact, though, because we learned in chapter 5 that both elastic cartilage and hyaline cartilage have perichondrium. All right. The only type of cartilage that doesn't have a perichondrium is fibrocartilage. Well, keep in mind, I always say that there's exceptions to the rule. Here's one of those exceptions. Okay, so the articular cartilage is going to lack a perichondrium. It will not have that covering. And it's going to be avascular, which we knew already. Right? Mature hyaline cartilage is going to be avascular. So within our joint, we have a space, and that's the joint cavity. And that joint cavity will be lined by the synovial membrane, which makes the synovial fluid. And the synovial fluid is wonderful. I love motor oil. In fact, I had my oil changed in my car last week. I love it when that happens because I know they're going to be draining out the garbage oil and putting in this nice, beautiful, golden tinted fluid that's going to lubricate the pistons inside of my engine and to help reduce friction inside of my engine. Well, guess what? All right, synovial fluid is similar to motor oil. Okay, it's viscous, it's thicker than water. It helps to lubricate the articular cartilage. So one, if it's lubricating the articular cartilage, it's reducing friction, but also at the same time, it's going to act as a shock absorber. And as that fluid is washing over the articular cartilage, it's going to help bring nutrients to the articular cartilage, and it helps to remove any of the waste that the chondrocytes may have produced because it's avascular, so it doesn't have a blood supply to rely on. So the synovial fluid does all of that work for the blood system or the vascular system. Pretty nice. All right, ligaments. We got ligaments. Remember what ligaments do? They hold bone to bone. What are ligaments made out of? Dense, regular connective tissue, very tough, right? So their job is going to be to strengthen, stabilize, and reinforce those joints. And so there's two types of ligaments that I want to discuss with you: extrinsic ligaments and intrinsic ligaments. The easy one, the extrinsic, those are the ones that you can see, all right, separate from the whole joint capsule itself. Okay, so they'll look like an extra piece of tissue near the joint. The intrinsic are going to be part of the joint capsule, right? So you'll see that certain areas of these articular capsules, they'll be thickened. And so they'll sit on the outside, all right, of these joint capsules, and they'll also kind of blend in to the actual joint capsule itself, adding more strength and stability to the joint. Right? And then finally, we have our tendons and our nerves and blood vessels. Okay, so the sensory nerves are going to have, we'll get into more details about the sensory nerves, right? But the sensory nerves are going to be located all throughout these joints, and they're basically going to give our central nervous system, our brain and spinal cord, feedback of what's going on at the joint. Are you flexing your elbow? Are you extending your elbow? Are you turning your wrists out or in? All that information, yes, you can look and see that going on by looking at it using your eyes, but also you have nerves all throughout those joints that are constantly telling your brain where exactly those joints are in position or relative position to your body. They call that proprioception. So you'll have mechanoreceptors, which are a type of proprioception. You'll have nociceptors, which are pain receptors that are going to be in the joints. And then you also have stretch receptors that will tell your central nervous system if a joint is being stretched too far and in danger of damage. So you have lots of sensory nerves there. And of course, you have blood vessels all throughout to help bring nourishment, all right, to the tissues there. And then finally, we have our tendons. Okay, our tendons, again, are going to be a dense, regular connective tissue that attach muscle to the bone. All right, now they're not going to be a part of the joints, but they will move the joints, right? And we know that tendons, all right, attach the muscle to the bone to help with movement at the joint, but also they can help to stabilize the joints. I had a patient of mine in which he played football, and his legs were huge, and his glute muscles were massive, and he was just a big, thick kid. And during a game, he had torn his ACL ligament. And it's a ligament that prevents your knee from sliding forward on itself. And he damaged that ligament. And so the trainers there assessed it, and they ran a bunch of tests on it, orthopedic tests, and he passed, all of them with flying colors. But his knee kept hurting and hurting and hurting. So we sent him in for an MRI, and it came back with a ligament tear. And he had so much muscle mass in that area and so much stabilization from his muscles itself that he was negative on all these sports medicine orthopedic tests. It was quite amazing. But anyways, and that just goes to show you how much the muscles can help stabilize joints. All right, bursa. Bursa sacs, their job, they're going to find them in and around joints, and their job is to help decrease friction there. And so we'll see, all right, bursa sacs are these sacs that have synovial fluid, and they're going to be found around ligaments, around muscles there. And a lot of it you're going to see in areas where tendons are going to be rubbing past one another. And again, what's their job is to alleviate that friction. So you can see down here, when we're looking at the knee joint, you can see we have a couple bursa sacs around the quadriceps tendon there. So they're just going to be in areas where a lot of things are going to be sliding by or moving past one another. And so their job is to help to prevent, all right, damage there and from things getting injured with excessive movements there. And then finally, we've got our tendon sheaths and some of our fat pads. And so basically what we've done is we've taken some bursa and we've lengthened them, and we wrap them around these long tendons, especially in our upper extremity, in the wrist, all right, in our fingers and down by our feet and our ankle there, right? We're going to, again, wrap them around those tendons where we see a lot of friction going on. And then the functions of fat, cushioning, energy production, insulation. Well, here you're going to see fat pads act as a packing material around the joints, right, to help fill these spaces. So here's a nice picture of some of our tendon sheaths, all right, and the tendons, these nice tendinous sheaths wrapping around it. And again, it helps to prevent friction here or damage to tissues all throughout. Big time here, especially when we're getting close to the, why am I having a brain fart here? Carpal tunnel. Perfect place to stop because talking about synovial joints and their movements here is going to be a nice long conversation for another time. So let's take a break here and